This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patient survive this podcast? It's up to you and the choices you make. Our episode today is called Electric. Want to know what pacifiers have to do with drugs? What toxin causes your brain to swell and how drinking too much water increases the risk? What drug of abuse is currently under review by the FDA as medicine? Listen to find out. It's 2 a.m. in the emergency department. You're looking at a box of stale pastries, debating whether or not you should have a second donut. Resisting its strong gravitational pull, instead, you click on the next chart. The patient is a 23-year-old woman with a seizure. Per the triage note, there's no prior history of seizures. In the room, she's asleep on the stretcher. You wake her up. She's lethargic but able to answer a few questions. She confirms no prior history of seizures, no medicines, and no supplements. That's as far as you get before she falls asleep again. Her vital signs are temperature of 100.7 or 38.1 Celsius, heart rate 110 beats per minute, blood pressure 150/70, with an oxygen saturation of 100% on room air. Her respiratory rate is normal at 18. The nurse gets the patient undressed as you examine her. Her pants are soaked with urine, her skin is sweaty, she has large pupils, her heart and lungs are normal, so is her neurological exam, other than her mental status. Essentially, we have a patient with new onset seizures with mildly increased heart rate and blood pressure and a borderline temperature. As I've said before, new onset seizures is an extremely common chief complaint in the ER. Question number 1, which of the following tests should we order? A fingerstick blood glucose, B, an EKG, a CT scan of the head, D, electrolytes. The answer? A and B are absolutely necessary. If you said D, though, you aren't wrong. We need the fingerstick to make sure this isn't hypoglycemia or low blood sugar. The EKG isn't out of concern for a heart attack, but rather to evaluate for an arrhythmia, which can present as a seizure mimic. I've seen this in real life, a patient who looked exactly like they were having a seizure until a glance at the monitor showed ventricular fibrillation. We do almost always order lab work, though in young, healthy people we don't anticipate abnormalities. Patients and families always want CT scans of the head, believing it'll show a cause of the seizure, but in reality, it's extremely low yield in healthy patients. An MRI does sometimes provide more information, but those aren't done emergently in the ER. As you reach your computer to enter the orders, the nurse calls you back into the room. The patient's having another seizure. A seizure is essentially a burst of uncontrolled electrical activity in the brain. So at this point, treatment is indicated. I'd use a benzodiazepine like lorazepam, brand name Ativan, to prevent another seizure. The patient's friend arrives looking anxious and jittery. You ask him what happened. He says just prior to arrival, the patient reported feeling unwell, asked for water, then collapsed to the grass. He describes generalized tonic-clonic seizure activity with contractions of all 4 limbs. You ask where they were and what they were doing. The friend hesitates, fidgeting. You tell him you need the right history to ensure she gets the right care. Eventually, he says they were at an electronic dance music festival. In this scenario, every ER doctor and toxicologist's thoughts immediately turn to drugs and alcohol. Of course, anything is possible, but common things being common, complications of substance use are at the top of the list. The friend says our patient drank alcohol and ingested another substance. Question 2. What is the likely cause of seizures in this patient? Pick your poison. A, alcohol, B, MDMA, also called Molly or ecstasy, C, LSD, D, psilocybin, or magic mushrooms. The answer is B, MDMA, popular at festivals and in nightclubs. It was popular in pill form, called ecstasy, in the 1990s and 2000s. More recently, it's in a powdered form, often called Molly. I'm always shocked how many people think it's completely harmless. No, it's not the world's most dangerous drug. It's certainly not fentanyl. But patients definitely end up in the ER after MDMA use, and deaths do occur. In fact, a paper on this topic from the 90s has one of my favorite titles, The Agony of Ecstasy. The prevailing opinion is that somehow Molly is safer than ecstasy, which makes no sense since they're exactly the same drug. So first, let me touch on what are sometimes called club drugs and then come back to MDMA specifically. One of the biggest risks with taking these things at a festival or in a nightclub is, like the risk with supplements, you have no idea what's really in it. There are tons of studies analyzing these drugs, both confiscated and voluntary donations. They all show the same outcome. People have absolutely no idea what they're getting. As much as 50% of Molly isn't even MDMA. Substitutions can be anything from sugar and caffeine to methamphetamine, ketamine, and cocaine. If you do get what you paid for, the concentration is extremely variable. Bottom line, patients may or may not be forthcoming about what they took, but even if they are, they don't necessarily know what they've been exposed to. We believe the friend's history, of course, but do we believe this is an MDMA exposure? Or do we think she took something else? Question 3. Which of the following is true? A. The patient is experiencing symptoms consistent with MDMA toxicity. B. The patient was given another toxin. The answer is A. Seizures due to MDMA use are a well-known complication. This is a pretty classic story, so I don't think we need to look much further. A good way to confirm our suspicion is with her lab tests, so I'm glad we sent those earlier. Question 4. MDMA toxicity causes what disturbance on labs causing seizures? A. Potassium, B. Magnesium, C. Calcium, or D. Sodium? The answer is D. MDMA causes hyponatremia or low sodium. Our patient's sodium comes back at 117 milliequivalents per liter. Normal is 135 to 145, so this is dangerously low. Hyponatremia is caused by an imbalance in sodium in water, either too little sodium or too much water. This is why sodium and other electrolytes are measured as concentrations in milliequivalents or millimoles per liter. One way to narrow down the cause is to look at the patient's volume status. Edematous legs or swollen legs can result in hypervolemic hyponatremia due to too much water from, say, congestive heart failure or liver disease. A dehydrated patient has too little water, which is hypovolemic hyponatremia, for example, from vomiting or diarrhea. Our patient's volume status is normal, making this euvolemic hyponatremia, classically associated with marathon runners and MDMA. Low sodium levels cause an altered mental status, seizures, coma, and require emergent treatment. If we wait, her brain might swell, becoming too big to fit in her skull and get squished out, leading to brain herniation and death. Lorazepam is the right choice for treating undifferentiated seizures, but it won't stop a seizure due to a sodium disturbance. Most IV fluids contain sodium or salt. However, she needs a lot more than the amount contained in a bag of normal saline. The treatment is 3% hypertonic saline, fluid with a high sodium concentration. If you screw it up, this treatment can be as dangerous as the low sodium she has now, and it's easy to do more harm than good. If you give too much, the sodium will become too high, resulting in altered mental status, seizures, and death. With too rapid correction, there's a risk of osmotic demyelination, formerly called central pontine myelinolysis. Essentially, if you try to correct it too quickly, the brain itself can't readjust quickly enough and becomes dehydrated. Patients develop locked-in syndrome, meaning they're paralyzed and able to move only their eyes. Nobody wants this. Calculating the sodium deficit and how quickly to fix it is very complex, and several different formulas exist. I like a simplified protocol, skipping the confusing calculations. You give 100 milliliters of 3% sodium chloride as a bolus over 10 minutes, and you can repeat this 3 times until the acute symptoms subside. The goal is to provide an urgent correction by 4 to 6 milliequivalents per liter to prevent brain herniation. So, back to our patient. Now you can't wake her up at all. She's tremulous, like she's about to have another seizure. You give several doses of hypertonic saline. She stops shaking and opens her eyes. A great sign. She is certainly not back to normal, but hopefully she no longer has a dangerously low sodium. The nurse draws more blood and sends another specimen to check. While we're waiting, let's talk about how MDMA causes hyponatremia. Interestingly enough, via 2 pathways, one due to the drug and one due to the patient. MDMA itself causes release of vasopressin, also known as antidiuretic hormone, from the pituitary gland. A diuretic is a water pill, so an antidiuretic, like vasopressin, causes your body to retain water, diluting sodium down to low levels. The second problem is if the patient drinks too much water, i.e., free water, while on NMDA. Drinking water to prevent dehydration is often encouraged in clubs and festivals. People may sweat due to dancing and hot weather or a crowded club. Some water is indeed good, but too much water exacerbates the low sodium already caused by MDMA's effects in the brain. After about an hour, our patient is now awake and alert, sitting up, talking to her friend. Her repeat sodium level comes back at 121 milliequivalents per liter. Still low, but not dangerously so. Water restriction for a short time should be enough to fix it from here. She's arguing with a friend, saying it must have been a bad batch of drugs, as it couldn't be MDMA, which everybody knows is safe. You tell her about MDMA's side effects. Eventually, she stops arguing, though it's not at all clear she believes you. Obviously, MDMA does a lot more than just affect sodium levels. What else does it do? Well, the chemical name gives us some information. It's methylene dioxymethamphetamine. So it's an amphetamine, the reason our patient had a fast heart rate, a high blood pressure, and large pupils. However, MDMA has only about 1/10 of the stimulant effect of regular amphetamine. In high doses, you can see hyperthermia with life-threatening multi-system organ failure, though this is pretty rare. I'm sure you know MDMA is different than classic amphetamines or meth. Why? It's the methylene dioxy part. Question number 5. This part of the molecule has a similar structure to A. Mescaline, which is peyote, B. psilocybin, magic mushrooms, C. LSD, or D. cannabis. The answer is A. Mescaline. Mescaline is a hallucinogen and increases serotonin levels. So does MDMA. This doesn't happen with other amphetamines. In fact, it's similar to hallucinogens like LSD and psilocybin. MDMA causes euphoria, feelings of an expanded consciousness and peacefulness, enhanced sensory perception, and heightened sexuality. It's classified as an entactogen, from the Greek meaning touching within. Less desired MDMA effects include restlessness, confusion, difficulty with concentration and memory. It also causes bruxism or tooth grinding. This is why you see pacifiers at festivals. We don't know much about the long-term effects of MDMA on the brain. More on why this matters in a few minutes. First, I want to talk about why MDMA has recently been the topic of controversy and headline news. A drug company called Lykos Therapeutics has filed an application with the FDA to manufacture MDMA specifically for the treatment of PTSD. Hearing about the controversy, I assumed it was a dry academic debate about data or statistics. In fact, the controversy is about crime and cover-ups. A word about psychedelic-assisted psychotherapy. There is some evidence use of hallucinogens may help patients during therapy. There are a few small but really interesting studies suggesting psilocybin, the ingredient in magic mushrooms, helps relieve anxiety and depression in hospice patients, for example. Anne Shulgin, wife of Alexander Shulgin, the famous chemist and psychonaut credited with popularizing MDMA, called MDMA penicillin for the soul. Despite the beliefs of utility from what some have termed a cult of psychotherapists, almost no data is published. It was kept quiet out of fear the FDA would schedule MDMA, which is what did happen in 1985. This is a pretty troubling beginning, in my opinion. Medicine, especially use of a mind-altering drug during therapy, shouldn't be done in secret. More recently, some patients with PTSD, including veterans, have reported MDMA helped. Fast forward to today, Lykos reports 86% of patients in their study showed improvement in PTSD symptoms, and 71% no longer met criteria for PTSD at all, versus placebo with 69% of patients improving and 48% no longer meeting criteria. It sounds great, right? So what's the issue? The issue is, can we believe this data, or has Lykos Therapeutics lied and manipulated it? First, the study isn't blinded because participants can tell if they get MDMA or placebo. The FDA was aware of this, and most agree that there's no way to do a blinded study. Second, Lykos is accused of recruiting both therapists and patients with biases toward the use of psychedelics, meaning both the patients and the therapists are more likely to report good experiences rather than bad. And it wasn't just bad experiences that occurred during the study. Crimes were also committed. A warning about the next minute of content. It may be disturbing to some listeners. I'm going to touch briefly on sexual assault. If you're a parent who prefers your children not listen, or an adult who feels triggered or wants to avoid it, please skip ahead 1 minute. A study patient paired with a husband-wife therapist team was sexually assaulted. The footage has been released and is extremely disturbing. The woman with a history of PTSD from sexual assault is assaulted by the male therapist during the study. She's clearly distraught and saying no. The reason for the male-female pair? It's thought to be safer after two therapists in the 1980s were convicted of sexual assault during MDMA-assisted sessions. Obviously, any violation of the therapeutic relationship is horrific. It's even worse when victims have an altered mental status and may not even be able to say no. These women were already in therapy because of PTSD due to sexual assault. It's horrifying. If you skipped ahead, we're back to our normal content here. Basically, this trial is full of medical and ethical concerns. It doesn't answer the question of MDMA treatment for PTSD. Many researchers are concerned the poor quality of this trial will derail future studies into the use of psychedelics. This news is really hot off the press. Earlier this month, an FDA advisory panel of independent experts asked to review the data, recommended the FDA not approve the application. Now, the FDA doesn't have to follow the committee's advice, but typically does. A decision is expected in August. This brings us back to the question of the long-term effects of MDMA on the brain. Animal data shows a reduced number of serotonergic neurons in the brain after MDMA use. Less serotonin is associated with depression and memory problems. PET scans in humans who've stopped using MDMA show decreased brain activity in regions related to emotions and memory. Why does this matter? Because if using MDMA changes our brains, and especially if it causes depression in patients already suffering with mental illness, this really big risk would have to be balanced with a big reward to justify its use in psychotherapy. I don't know what the future holds for MDMA specifically and psychedelics in general, but I am interested and waiting to see. This is a fictional case, as are all our cases to protect the innocent, but it is based on real poisonings. The last question in today's pop culture consult: which of the following artists doesn't refer to MDMA in lyrics? A. Kanye, B. Jay-Z, C. Madonna, or D. Taylor Swift? Follow our Twitter and Instagram feeds, both at PickPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Finally, thanks for your attention. I hope you enjoyed listening as much as I enjoyed making the podcast. It helps if you subscribe, leave reviews, and/or tell your friends. All the episodes are available on our website, pickpoison.com, Apple, Spotify, or any other location where podcasts are available. Transcripts are available on the website. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.